As we start the formal part of the presentations, I will give the first presentation just starting in a second here, but I'd like us to welcome our faculty for today, Dr. Abanar, who's arrived and is sitting in the back. Very pleased to have him here. He's from the University of Indiana in Indianapolis, so very pleased to have Dr. Abanar here. And then Dr. Harrisol, Jean-Luc Harrisol, very pleased to have him here, and he comes all the way from France, and so he is a world-renowned expert in the area of transplant, stem cell transplant, originally bone marrow transplant for myeloma. So we're really, really pleased to have him here to discuss what is the current status or recommendation for transplant and myeloma. And as we learned yesterday, you know, there are some open questions there. So you should take advantage of the opportunity of having Jean-Luc here for our meeting. Dr. Richardson is currently on a plane, and hopefully that will land somewhere close to here. And he will be over here a little bit later in the morning, but he made a very, very special effort to be here. Some of you may have seen the agenda for this meeting 2 or 3 months back, and we had hoped that actually his colleague, Dr. Ken Anderson, would be here, and he was actually scheduled to be here, could not make it at the last minute, and so we're really grateful to Paul for changing his schedule and being able to be here to give the presentation about the new drugs and relapse therapies after lunch today. So you'll have a chance to thank Paul when he arrives a little bit later. So what I'd like to do is just to start us off and introduce some of the basic ideas about myeloma. And so if we can just go to the what I call fast facts for 2019. And so what I've done today is focus on aspects of myeloma which are a little bit more on the new side. Most of you here have unfortunately known about myeloma, many of you for a number of years, and so you're familiar with a lot of the kind of basics of myeloma. And so the question is, how have things been changing over time? And the good news is that things have been changing a little bit in terms of the testing, in terms of the options, and the terms of the approach to the disease. And so what I'm going to do is kind of lead us through starting with the testing and moving into the different aspects of treatment, just pointing out where there have been important new changes that you might want to be aware of. I'm going to focus on the idea that treating early is quite important now to avoid problems with the myeloma, and we saw already that 24% of the patients in the room were diagnosed very early, and this turns out to be advantageous. What are the required tests these days? What are some new classifications that you need to be aware of in classifying the disease or classifying the risk status for the disease? And to put things in perspective, what are the outcomes that you should expect? What are the chances of response with the current therapies in broad terms, and what are the expected outcomes? And then just to look at the concepts related to relapse and the options for trials and new therapies. But as we start this group, one of the main things that we want to just remember is that getting informed is what it's all about. So knowledge is power, as Susie emphasizes. That's the way to go. Once you have the knowledge, then you have the chance to talk to the doctor in an informed way. And also to think about the emotional aspects of the disease, where it is important to be hopeful, but not just passively hopeful, but actively hopeful, and to become resilient and to become, if possible, a warrior in some fashion. So I'll talk about how that might be possible, all right? As far as the early disease, we're going to show you a video later of what we've been doing in Iceland. But basically, we have been screening the whole population of Iceland to see if they might have MGUS, the very, very earliest form of myeloma. And the bottom line for this is that we've identified 4,000 new individuals who have MGUS, which is pretty amazing, really. And so the opportunities that are coming out of that are to see, well, who is it that gets MGUS? Who gets MGUS? And then what seems to be causing that MGUS? Are there things that are maybe leading to the development of MGUS? Now, if you have MGUS, we mentioned yesterday, there is a 1% chance, so it's a very low chance per year that it would move forward into smoldering or active myeloma. But if you have 4,000 people to start with, that means that there are actually 40 people each year who are moving forward into more active disease. And so you can study what are the mutations, what are the factors that might lead to the development of active disease. And this is a huge opportunity to understand that process and to understand possible ways to intervene early and maybe even prevent that early activation process. So this is a big aspect of new research that is going on. And I just want to mention two aspects about, well, what is causing MGUS or what is causing myeloma. And the first thing is that there is a lot of new information, new what we call epidemiology studies looking at exposure to a whole range of different chemicals and the risk of getting myeloma. And so I've referenced a couple of papers on this slide. One of them is from the American Cancer Society. Another one is from the group at the University of Berkeley in California, where they're very, very interested in which chemicals can cause cancer. And so there really is important information about chemicals that may be linked to the development of not just cancer, specifically myeloma. One that has been in the news, which I touch on here, is the weed killer Roundup, where there is definite evidence now that Roundup is not safe and can cause bone marrow cancers, lymphomas, and as I said yesterday, there was a huge legal settlement where a gentleman who developed lymphoma in California won a $200–300 million settlement against Monsanto based on the presentation of what was felt to be good scientific evidence. The other thing which is emerging is that there was a recent report looking at the age of onset of myeloma, and mostly doesn't apply to people in this room here, but myeloma is being noted in increased frequency in younger people, and this has been linked to the increased occurrence of obesity. And so obesity is emerging as an important risk factor related to myeloma, so something just for you to be aware of. And so if you track patients from early disease into active myeloma, if it's 1% a year, what that means is that after 20 years, 80% of the patients still have MGUS, but 20% don't and have gone on to myeloma. And so we are having that opportunity to study that process on a regular basis each year, and we're really optimistic that we'll learn a lot about that. So moving forward to what are the tests that everybody should be aware of and getting as a basis for decision making. And so it's a very compact list of tests that you just need to be very familiar with, and probably most of you are. So the key test for myeloma patients is that you get this electrophoresis test of the blood or the urine, which is called SPEP, serum protein electrophoresis, or UPEP, which is urine protein electrophoresis. And then to find out what is the type of the myeloma protein, you get immunofixation, which is IFE, and that tells you that your myeloma is IgG or IgA, and if it's kappa or lambda. And so this is the fundamental test to know what is the key marker for your disease. And so if you do not know what that is, that is something to ask your doctor. What is the type of myeloma protein, and what is the level of that in my blood or urine? This is the key thing to monitor what's going on, if you're responding to treatment or not. Now, as the myeloma is building up in the bone marrow, it can impact the blood count, so we need to track the red cells, the white cells, the platelets. You can get effects from calcium and protein on the kidneys, so we need to check the full chemistry panel for creatinine and calcium. We need to track the free light level, which can indicate light chain disease or also activity of the disease. The beta-2 microglobulin is used for staging. And then, of course, the key test is the bone marrow, which we do at the beginning to assess the percentage of the plasma cells. And also, you need the bone marrow test to do that FISH testing that we talk about, the genetic testing on the bone marrow cells. And to assess the bones, we need to do some type of x-rays or scans. Now, the way that we look at those tests throughout the course of the disease, at the time of initial diagnosis, you can have at the top there MGUS, which is based upon a low level of protein and a low percentage, less than 10% plasma cells in the bone marrow. But as you move forward into smoldering or active myeloma, the levels of these different tests go a little bit higher. The free light test can be higher, the bone marrow percentage can be higher, and then ultimately at the bottom, you have those CRAB criteria where there has been enough disease to develop increased calcium in the blood, kidney damage, anemia, or the development of bone lesions. So we look at this at the time of diagnosis, but it's important to remember that once you go into remission, we are tracking those exact same tests to see if there's new active myeloma which would be requiring a change in treatment or a new treatment. Now, one set of criteria which a number of patients have been anxious to know about is if the disease is smoldering, either early or even later, what are the levels that seem to correlate with the disease becoming active? And so these are some important numbers that may be helpful for you. If the myeloma protein level is going up above 2, if the bone marrow percentage is going above 20%, and if the free light ratio is above 20, those are indicators of a movement toward important activity, particularly if you have some chromosome abnormalities. In this setting related to activity or not activity, it seems like the presence of the 1q plus is important, as well as the 13q minus. So those couple of chromosome changes seem to be important in that process. And so this just shows you the different curves. If you have all of those things, there's a risk that things would become active within about 1 year or maybe a little bit less if you have all of these different factors. The other thing that you should be aware of is that the testing for myeloma is in the process of really changing. And so instead of getting just that SPEP, very soon there's going to be a new test. It's already offered at the Mayo Clinic, where if you send in the sample, they will send back the result, which is the result of a new test, which is called Mass Spectrometry, which is a very, very sensitive way to measure your myeloma protein. And so you may start to see that mentioned on some of your lab reports, especially if they're sent into the central lab at Mayo Clinic. And so this is a new commercial method. It identifies the myeloma. It's quite useful because if you're taking daratumumab, the monoclonal antibody, it can distinguish the antibody, the daratumumab, which is the medication, versus the myeloma protein, and it helps you to distinguish those two and know if you've had an excellent response and not confuse it with just the drug being present. And this is going to be, fortunately, quite affordable, costing around about $180 for a test. So it's actually cheaper than some of the other testing that we currently use. And so this just shows you the old method, where you can see there that we have a monoclonal spike on the top, and then using the new method, it has a slightly different configuration where you can see that you have an M protein, and then if you have daratumumab, That's a monoclonal antibody. It also shows up as a spike. The green arrow shows the daratumumab, and the red arrow shows the monoclonal protein at the bottom. So you can see that you've got the daratumumab in your system, and then if you are having a response to treatment, the red one, the protein level is going down. So this is something that you're going to be seeing for the future. As far as getting testing for your bones and for activity of the myeloma around the body, you have several options, including the PET scanning and the MRI. A big advantage of the PET scanning, which you can see here on your right, is that you can see multiple lesions, the hot spots where the sugar is taken up into the active PET scan lesions. And so the advantage of PET scanning is it shows if the myeloma is there and if it is active. So you can see these active spots. And so what has happened in recent years is that we have these different options for evaluating myeloma. We used to use just traditional X-rays. And so you can see here that if you are looking for bone lesions at the beginning of myeloma, the best way to do that now is with a whole body low-dose CT scan. So that's the testing in orange or yellow there. So how many people here have had a whole body low-dose CT? A few people. All right, yeah. So increasingly, it's a very rapid test, and it scans the whole body, and so this is a good way to check if the myeloma is causing bone lesions. Now, as I mentioned, you can get a PET CT. The main advantage of that, especially after treatment, is that you can see if there are any spots of myeloma left and if they are active or not. MRI can be used throughout the disease and shows if there are active spots in the bone marrow, and is probably what we would call the gold standard for monitoring myeloma in the spine and pelvic areas, just to see the status of the disease. The FISH testing I mentioned is quite important. On the left, you can see the pictures of the chromosomes in the myeloma cells. You can see that the chromosomes are painted different colors with the FISH testing technique. And so based on the different colors, you can see that in the middle, there are different colored dots. And so if you have different colored dots together, then it tells you that different chromosomes have come together. So if you have, for example, 414, then you can have a red dot and a green dot together. And so when the pathologist sees the red dot and the green dot, he knows that there's been a 4 and a 14 coming together. The red and the green have come together. And so this is a visual technique where the pathologist is actually looking for those dots. So whenever you have people involved, it's not necessarily the most reliable test in the world. You know, if the patient is coming in and the pathologist who normally is reading the FISH test is on vacation, you know, and you have the backup pathologist who's not used to looking at colored dots, you know, you may or may not get your best result. So it's best when you have tests which are fully automated. And so for the future, we're looking to move away from FISH testing. One option is to use gene expression profiling. However, this is still not in an automated way and doesn't give you the exact same results, but it can be useful to identify high-risk disease. Now, as far as what we call the risk of the myeloma, it can be classified as high risk or low risk. And I want to point out that we've kind of shifted the classification a little bit recently. And so now we're mostly just interested in high risk or not high risk. And so at the top of the slide here, I've listed the 4 categories for what would be high risk, which is the chromosome 17, the 414, the 1q+, and then either 1416 or 1420. Now, a little bit of a new twist to that is that especially as the disease is advancing later in the disease, we can see patients who have multiple abnormalities, what we call 2 hits or 3 hits, double hit or triple hit. And so if you have multiple of those high risks, you can be called a double hit or a triple hit. And so we're obviously especially concerned about those. But at the bottom, you can see that actually we can be concerned, but we're not exactly sure what to do about it. This is a very, very active area of research, which is to, if we find those, what are the best combinations to use some of the newer combinations to try to overcome these high-risk features. And you're going to hear more about that. So based on all of this that I've been showing you, the treatment of myeloma is slowly moving into two categories. And so you have the red, and then you have the green. And so over on the red side, you have the aspects where you just treat like myeloma, and then over on the green side, you just observe the patient. And then in the middle, what we're trying to do is have high-risk smoldering such that we are secure enough that you could just treat it like myeloma, and then for low-risk smoldering, you'd be perfectly happy just to follow and to monitor. So basically, it's going to be good just to have a decision to treat or not to treat. And what you're going to be hearing about for the rest of the day, which I'm not going to focus on particularly, is what are the options when you're going to treat for frontline, for maintenance, and for relapse. What you can see right here is the number of options that we use frontline has become quite small. We have some standard or optimized recommended therapies up front, just a few of those. And then for maintenance, just a few options, either Revlimid or a proteasome inhibitor, which could be Velcade, Kyprolis, or Ixazomib. But what Dr. Richardson is going to be challenged to go over with you is what are all of those different options in relapse, and in what fashion would be best to use those. But I want to just kind of set the stage in terms of, well, where are we with the therapy for myeloma in 2019? And so one of the main frontline options for myeloma is Velcade, Revlimid, and Dex, VRD. And there was a study which I led for the Southwest Oncology Group, which we recently updated and presented at ASH. And so the question is, if you use this VRD, one of the main frontline options that we have, what are the outcomes for that? And the main thing I want to point out to you here is if you look here, the overall response rate with a VRD is a little bit over a 90% response rate. And so the main expectation for a newly diagnosed patient right now is that, you know, over 90% of the time, we're expecting that that VRD will produce an overall response. And that about 75% of the time, that response will be excellent. It'll be a very good partial response, VGPR or better. Now, you can get good responses with just RD, but what you can see here clearly is that you can do a better job with the 3 drugs versus the 2 drugs. Now, if we look at that in terms of what are the outcomes, it's really important to have some perspective of how things have changed in the last 10 to 15 years. So it used to be that if you turn to the pages in books, we don't really turn to the pages in books anymore, but I used to remember when patients would say they went to the library, but I haven't had that happen in a while now. When you go to the internet and you know, you scroll down and see, well, what is the outcome for myeloma? It's much, much better than it ever used to be. And so now in this study, after 7 years of follow-up, over half of the patients are still alive and doing well in this study. So things have changed dramatically in terms of outcomes. And if you add a stem cell transplant on that, what you can see here is that close to 60%, if you have VRD plus a transplant, are MRD negative, where they have a dramatic response. And you can see that with that response, patients are staying in remission a lot longer. And so we've reached the point with just standard therapies using the novel combinations that we can have a high expectation for good outcomes. And so we have these various options, and the good news is that we have a lot of options in the front line, in new agents for relapse, and exciting new therapies. But what we're going to talk about today is how do we evaluate all of these different options to have the best therapy recommendations for you? A major aspect of coming together for these seminars is to have you be informed and to be in a position to talk to your doctor, but also to understand that it's important to sort of regroup after the diagnosis. When you're diagnosed with myeloma, this really changes your life forever. I mean, you have this thing which you have to deal with, and so you need to figure out a way to adapt to that and to continue with your life. And one reason I just showed you the data that I did is that nowadays it is possible to regroup and have quite a high expectation to live for a lot of years, as you saw already in this room, for over 5 years, sometimes over 10 years, and to develop that hope of how well you can do in your individual cases. So you can go from this position of being completely terrified and understanding a very complicated disease for developing, to developing true hope, which is based upon understanding the disease and becoming knowledgeable and being able to talk and discuss things with your doctor and also with other patients and support people in this room and reach the best decisions. Now, it is important to regroup and become calm, to try to stress down and really readjust and focus on, okay, what do all these things mean to the lives of yourselves and your families moving forward. But as has been touched on a couple of times already, when you have myeloma, you do not have the luxury of sitting at the end of the pier and just chilling out during the day. You do have to do a few things to figure out what's going to be happening. And so what I'd like to emphasize very strongly is that it is important to get the knowledge that you need and try to develop a sense of resilience where when new information is coming, you're in a position to talk sensibly, to ask the right questions, and see what the next best options for you. And in the process of doing that, you become resilient and you can become what we call a warrior, where you and your spouse and your partner can really be in a position to really work strongly to achieve the best outcomes. But even warriors do need sleep. And it is important to make sure that you're not getting overly exhausted and that you really do take time out despite all the challenges that you might face. This is an interesting study recently which showed that when you're sleeping, your chromosomes are actually healing up, which is kind of an interesting new observation. But the final point that I want to make, which is demonstrated in the room right here, is that you need to learn from each other and to support each other and to get all the help you need. Support is key, and we get advice from the animals around each other, around us, who help each other, and it is remarkable to see all of the images of animals who remarkably do help each other in a very natural way, and so we need to learn to imitate our animal friends here. So thank you for your attention. All right, so we have time for some questions at the beginning here. So Dr. Abanar has a wonderful scooter that I haven't actually seen before. Here comes Rafat.
Yay!
So, yay! So Rafat is recovering from an ankle surgery, which is coming along nicely, I believe.
Yes, sir.
Dr. Hariso has not had surgery, and so he's scooting up a little bit more slowly. All right, so just a few questions to begin with here.
Okay, great. Question? All right, we have one over here.
So your slide, I'm over here.
Yeah, I'm
Hi,
seeing you, yes.
Good morning. Your slide on the future of multiple myeloma,
Yeah, future therapy, yes.
You have a new high-risk smoldering column with a date of 2/2020. Are the criteria being rewritten for high-risk smoldering?
the idea of this slide is that over on the right, you have the CRAB criteria, which is active myeloma, and then you have the myeloma-defining events, which you're probably familiar with. And then for the high-risk smoldering, we have been doing an analysis to see what factors indicate a risk of progression. And so those new factors are if the spike is more than 2, if the bone marrow percentage plasma cells is greater than 20%, or if the free light ratio is greater than 20. So it's called the 2-20-20. 2-20-20. And then over on the right, I actually did not identify new, where it says new over to the right there. And that new concept I'll actually talk about later in the day. That's high-risk biochemical relapse. And so to do the best job in a newly diagnosed patient, we can treat high-risk smoldering. To do the best for patients who are relapsing, you can treat biochemical relapse. And I'm going to talk a little bit about that later. Jean-Luc.
Sorry, I would like to ask you a question to make it clear. For new high-risk smoldering multiple myeloma 2-20-20, is it routine practice to treat them as a multiple myeloma, or is it only within clinical trials?
Only in a clinical trial. Okay. Yeah, so these are the criteria that we're using for the clinical trial. So right now, we don't know the pros and cons of that early treatment. The proposal is that treating early, you would get better results, and we do have evidence for that. But this is really the first time that we're using those criteria as a basis for treatment in the trials.
On your slide about high-risk myeloma FISH information, we've spoken about this. The 1Q positive, I've gotten so many different opinions about whether that really puts you into high risk. I was wondering what the panel felt about that.
Well, that's a very important point. For high risk, what I put on this slide, for high risk, I put 17P, 414, and then I have 1Q plus, and then I have 1416 and 1420. And so maybe Rafat and Jean-Luc, you would comment on the 1Q plus. I think that we have not been really putting that 1Q plus into that high-risk box so much. However, there is increasing evidence that it probably should be there. What do you think about the 1Q plus?
Well, I think that the incidence of this cytogenetic abnormality is quite high. It's up to 30%.
Yes.
The prognostic value is less than translocation 414 and 17P. But since the number is high, there is a risk, increased risk. So I think in future classification, 1Q amplification should be included in the high-risk factors. There is a concern regarding translocation 416, which is rare, 2%. Yep. And the prognostic value is not that sure. Some people say it's poor prognosis, but some people say with newer treatment it's less aggressive than thought initially. I think that it's a correct classification, and we certainly have to use this for comparing treatments, and maybe in the near future for deciding treatments, having different treatment for high-risk patient and standard risk patient.
I think that the
double hit.
And for the double hit and triple. So, but I mean, what I put in red there, I mean, is the disappointing part is that, you know, we have the classification now, which I think we're comfortable with, but we don't have clear guidelines about what we want to do about it. And so I think that this is the basis for some new treatments to see what would be the best options.
I think still the problem is that it's quite superficial. When you say 1Q plus, what does that mean? You know, you have an addition of some arm of chromosome 1. I think the science is really looking into what happened at the molecular level where sort of drive these cells to become more resistant to treatment.
Right.
And unfortunately, we haven't been able to do better sort of genetic analysis of the myeloma clones that they'll
Right.
be able to tell that.
There is a one new, with regard to 1Q+, I'll just mention, there is a new specific treatment for 1Q+. It turns out that when you have 1Q+, you have something new that pops up on the surface of the myeloma, which is called CD46. Now, daratumumab, it works against number 38, okay? So anti-38 is daratumumab. Well, there's a new anti-46, a new monoclonal antibody against CD46, which works specifically in the 1Q+. And this is a trial that is just starting. Actually, the first patient will receive treatment this coming week at University of California, San Francisco, UCSF. So Dr. Tom Martin and his colleagues are starting a new trial for 1Q+ patients using anti-CD46. So this is kind of exciting and new. So we'll see how that works out.
Jonathan?
Okay, thank you.
Yeah, you were talking about the fish, and then also mentioned the gene expression profiling. And I had a situation where my fish came back as high risk from -17P. My gene expression profile came back as low risk. And I
Right.
didn't really know how to, you know,
Right.
where to,
So
where
that's
to go with that. They seem to contradict each other. Does that,
that's a tricky point. Yes. So so low low risk GEP, but 17P. I think that we're still struggling with that. So that, for example, on the fish testing, we need to look at the number of cells that have it. So sometimes there can be a 17P, but it's just present in an occasional cell. And so what's called positive can be if you have more than a certain number of cells and 20% of them have the chromosome abnormality. And so I think that we need to move forward from this kind of risk stratification to some new and better ones for the future, because you can get these conflicting results.
Michael?
Yes. Are there any new or more accurate methods for determining dosages for individuals?
Drug dosages for treatment? Right. So I guess the question is, I mean, we have standard dose adjustments based on size and weight, so what we call meters squared, and so we make those adjustments. I guess what we don't do is...
For oral medication.
Yes.
Yeah, for pills, we
Yes.
don't. And that's the problem, I think, is just one size fit all, and we know that doesn't work. So that's why I think, and I'll talk about it in my supportive care talk, is that, you know, this is an ongoing evaluation of efficacy and side effect. So you need to be communicating with your treating physician about how you feel, and they need to say, you know, and ask a question, is this the right dose for my patients? Why they're fatigued? Why they're dropping their counts? Should I be adjusting the dose? So when you start with Revlimid 25 or Ninlaro 4 milligrams, is that the dose that everybody needs? And my experience says no. I mean, I have patients who are on 5 milligrams of Revlimid and 1 milligram of Ninlaro, and they're doing fine. So they're responding and they don't have side effects. So this is should be individualized, and every patient should be free and able to talk to their physician about that.
Right. But in general, related to age and what we call fitness, being fit or not fit, you know, performance status and the like.
Renal function.
Huh?
And renal function.
And renal function, yes. The broad concept is that it's better to go ahead and reduce the dose at the start rather than give the full dose and then have, you know, the blood counts crash and have problems and then make the adjustment later. And so what we call prospectively reducing the dose based upon age, renal function, and what we call comorbidities and fitness, it's much better to do that. And one of our colleagues, Dr. Antonio Palumbo in Italy, is very much focused on that in recommending these sorts of adjustments up front.
Good morning,
Hello.
Doctor.
Good morning, Anne.
I'm just kind of an advocate here, but you talked about this new blood test that Mayo Clinic is going to do.
Yes.
And is this to trace the progression of the disease? And in the future, is this going to reduce the number of times that the patients have to go for a bone marrow biopsy?
Good question. Yeah, I think the answer to that is yes, the second part. So this mass spec test is substantially more sensitive than the SPEP, the regular way that we're measuring the myeloma protein. So it's more sensitive than the free light test and the SPEP test. And so this means that it will be possible to monitor the myeloma at much, much lower levels and, as you say, avoid the need for a bone marrow. And so I think it'll make the monitoring much more accurate and much more sensitive. And it'll take some adjustment. I think that we'll all need to learn what the results of this new testing mean, because we're not used to getting those results at those very low levels. And it may be that these patients where we thought the myeloma protein was 0, it's not 0, you know, and then we'll be tracking those lower numbers, and I guess we're all going to have to learn how to deal with that if we want to change the treatment or not, perhaps.
Well, what would be the name of the clinical trial if you were interested in the high-risk smoldering myeloma? And do they reevaluate you at the time?
In the U.S., we have this trial which is called the ASCENT trial, ASCENT, like climbing a mountain.
Okay.
And it's open at about 12 centers around the U.S. It's open at Moffitt here in Florida, for example. But it's open at several centers, 12 centers around the U.S.
And my wife wanted to know if multiple myeloma was contagious. I told her no.
No, I think is the simple answer. I mean, there's some complicated cases where there's been some questions about that, but the simple answer is no. We don't have no.
You know, but you remember
Yes.
Kyle's
Houses and spouses.
Houses, yes.
Houses. There are some crazy cases where, now Dr. Kyle, one of our, most esteemed colleagues, reported cases where people living in the same house, so he talked about houses and spouses, where people living in the same house both got myeloma. And was that because it was infectious? Well, I think he decided that it was because they built the house out of rocks that contained radon, that there were radioactive rocks that they built the houses out of. But, I mean, so it's been discussed in the past, but basically the answer is no.
I have two questions. One is, I was on the Velcade for a couple of years, developed the necrotic jaw. Can you ever go back on Velcade?
You mean Zometa?
I'm sorry, I meant Zometa, yes.
Zometa.
ONJ and Zometa.
Yeah, go ahead.
So ONJ, we'll probably talk about it later too. It's when you have some jaw destruction related to imbalance in bone formation related to getting the drug Zometa, which is very important. Drug Zometa, and denosumab, 2 important drugs. About 3% of patients will get this bone destruction. The most important thing is about early detections. It can reverse, it can get better, and if your bones are getting fragile again, I think you should go back and take Zometa, and we've done that. So it's not that, if you had ONJ once, you're not going to need more treatment for your bones, because the worst thing that happens is that you break a bone in your spine and you become paralyzed. So we need to preserve the bones, and it's a clinical judgment. You have to weigh the risk and the benefit of anything you do.
Great.
Okay,
And another question.
we have time for one more question.
I'm just wondering which Mayo Clinic is doing this spectrometry testing?
Oh, it's not the Jacksonville branch, it's the one in Rochester.
Okay.
But what happens is, you can ship it there. So many of your SPEPs are actually already sent there. It's called Mayo Medical Labs, and they have a big website, and so a lot of the doctors, I'm sure the groups, probably the group right here in Boca, they probably already send their SPEPs and UPEPs to Mayo Medical Labs. And you just need to mark an extra box if you would like to get this mass spec done in addition. So it's a routine thing now.
Okay, I think that's it.
All right. Well, thank you.